Well, I think some of that is usually there is some lag sometimes between, the information when it first appears and how it trickles down into the practice, if you will, practice parameter. And sometimes unless you implement a change in the practice parameter, it doesn't get more widespread in terms of its scope. So that's the first thing. The second thing is, the practice patterns have been so established for a while that they are so ingrained. So when you have a held belief that something is not common, it takes a little while for the wheels to turn before you realize it's more common than you think. So that's what I would refer to as the culture of practice. So that's the second factor, the culture of practice. The third factor I would imagine is because the presentations, unless you have a highly specific clinical picture, like, for instance, the bullseye rash, that will be a perfect example, and so on. If you really have a little bit of an atypical rash, you may or may not remember that you were bit by a tick. You don't remember where it was. You don't know if it's an area where it's potentially endemic or not. Several things can present in a manner that could mimic, Borrelia infection. So, you could have a little bit of a rash and low-grade fever, and people will more be likely testing you for something like early lupus. You could have some joint aches and pain, and people would tend to think more of arthritis first, because in terms of common frequencies, those are the things usually you tend to see more often. And it really is after the initial screen is negative, and particularly, hopefully, if someone brings up the notion that there was an exposure to tick or a visit to an area where there was a high representation of the borreliosis, or unless the treating physician thinks of it and orders the blood test, it's often in our experience can be missed. So this is one aspect of the clinical presentation. The other aspect is once the condition, goes beyond the primary stage, the other manifestations, surprisingly, are actually even less specific. So, like I told you before, you could have, for instance, low-grade inflammation in the meninges, which are the covering of the brain and the spinal roots, or you can have root problem. We call that inflammation in the root, radiculitis. And other things do that. So when you see this, unless you suspect that the patient may have had Lyme or borreliosis, it's very difficult, to diagnose it unless you think of it and request the test. So it can be missed. Some symptoms, for instance, in the United States in particular, you can have sometimes some types of neuropathy, or if you get things like, mild low-grade headache, difficulties concentration, patients refer to that as brain fog or mental fog, a little bit of a mood disorder, particularly if somebody doesn't diagnose the problem, and then you get frustrated and, people get a little bit of a depression, a little bit of anxiety. It becomes customary usually to attribute the problem to something different rather than trying to do the investigative work. So, that I think the full cycle comes to the education. If we can raise awareness that, it really is logical to think of Lyme disease. It is logical that probably the initial condition may not have been treated or treated adequately. And now the patient is left with some residual dysfunction. It doesn't hurt to check for it, because you may find something, and if you find something, you could actually perhaps treat it or revisit the treatment or rethink of the process and what might have happened. Well, so I think again, this is the dilemma we have with the testing, and I think if the patient has, let's say, a classical bullseye rash, that is highly specific for borreliosis. If you do the blood testing early enough, you may not find the entire panel, that's being positive as requested by the CDC. So that is one aspect of the testing. The other one is if the patients are treated, sometimes they are left with a couple of bands that are positive. So particularly the 41 kD, it's commonly positive for a long, long time after that. So by itself, it's sensitive, but it's not very specific. So I think the education should focus on what are the testing parameters? You ideally want to look not only for the chronic antibody that is a marker of the memory for the condition, that will be the IgG, but also you want to look for the marker of still ongoing active condition, that's the IgM. And the CDC criteria are pretty characteristic and very well standardized, but sometimes, patients have the symptoms, and instead of, let's say, having 5 bands, they have 4 bands. And I think that is where we need more education from the infectious disease community on what does this mean. If you have a presentation that could mimic, either borreliosis, let's say joint problem without neurologic problem, or in our field, neuroborreliosis, neurologic complication of Lyme disease, and you do the blood testing on somebody, and they have 4 bands, what's the next step? So I would like to suggest perhaps that maybe a lumbar puncture is in order, because if you do a lumbar puncture, and the spinal fluid is impaired, then I would treat the patient for neuroborreliosis even if they only had 4 bands. So I think, that is sometimes you get specific bands in the spinal fluid, and that is more characteristic for the neurologic picture of borreliosis. The third thing is there are some assays where people are looking at, for instance, looking for fragments of the C6 peptide. And there is a debate on whether, you have some residual C6 peptide if you have residual infection. Some also are looking at a technique called polymerase chain reaction, PCR, and what they do is they amplify whatever blood specimen or spinal fluid specimen and see if they can detect a higher number of Borrelia fragment in it. So I think if all this is done and the patient testing is negative, the odds of having an active infection or an active neuroborreliosis in the case of neurologic complication is virtually very, very small. And chances are, unfortunately, now we are dealing with either some type of a residual low-grade inflammation or residual, immune response that's remaining in the nervous system. And I'm not saying that this, should not be addressed. It should be. But I think addressing that condition, if you will, in that particular situation with chronic treatment with antibiotics is very likely not useful or helpful. On the other hand, if you find some of these markers, as positive, then I think you need to weigh the evidence and decide, should this patient be treated again? Maybe the treatment in the first place was not long enough or adequate enough in terms of dosing, or maybe the antibiotic that was given in terms of choice was not, sufficient. And that takes us back to the point that I think you asked me last time, a little bit before, was the role of co-infections. Have we treated one infection, but did we not treat another co-infection that happened to coexist with the Borrelia? My preliminary feeling about these studies is that this is more likely to tell you who are the subset of patients who are more likely to be left with residual symptoms, whether it's the sign of an active infection or not. So I think the patient who are more likely to have the delayed stages, the post-Lyme syndrome, if you will, are probably a subset of patients who may or may not have been treated according to the CDC criteria, but somehow there is something about their immune system that's making, residual inflammation, residual remnants of something in their body. Now, whether that remnant is a fragment of the Borrelia that by itself is not infectious or contagious anymore, but is still sufficient to cause, low-grade inflammation, if you will, in the machinery, the immune machinery in the body, that could be one possibility. Or the other possibility is that the Borrelia now is really gone, but what's happened, your immune system is producing certain, inflammatory markers, antibodies, we call those cytokines, that could be causing some of these persistent inflammatory reaction. We tend to see this, for instance, in other infections. Example, for instance, you could have mononucleosis, Epstein-Barr virus, and the virus is out of your system, and you do the blood test 6 months later and 12 months later, and all what you're left with is the IgG antibody, which means you got exposed to mononucleosis. But then some patients are left with significant residual incapacitating difficulties. And when we measure inflammatory markers and immune markers in these patients, there are usually some deviations from what you expect. And the idea is that the viral infection has caused some deviation in the profile, the immunologic profile of these patients, and that by itself is continuing. So I think it depends on how specific of a what we call cluster design or CD marker you have. So some people feel that some markers are more specific than others. I am not. That's not, frankly, my area of expertise. I mean, I read about it and I hear about it, but that's the impression I get. But I do believe that a certain subgroup of patients who had Lyme disease are left with some degree of residual ongoing inflammatory problem, and that whether this is the sign or the expression of an ongoing active borreliosis versus just an independent immune process due to one of the two mechanisms I mentioned cannot be yet determined without further study. And I think we're going to find down the road that the treatment is a little bit different for those. You have a separate immune process versus some remnant of the Borrelia left in you versus a reactivation of the borreliosis. I think those are going to be 3 different conditions which require 3 different pathways of treatment. Well, I would say this is not probably unique to Lyme. It's more common probably in the subpopulation of patients who happen to be particularly in areas that are not culturally or historically highly, endemic or have a high prevalence of Lyme. I think, if you were in Connecticut, for instance, or some parts of Massachusetts, like in Wisconsin where I was, etc. I think people tend to think of that. And if you have the history or if you test a patient and find out, for instance, they have 3 bands or 4 bands, that they've had something before, I think particularly what I found is in California, first there is some tendency to believe that Lyme disease is really very low prevalence to virtually non-existent in California. I mean, that's what I heard when I first came. Second, when you don't see active signs of infection, but the patient is still complaining of symptoms, muscle aches and pain, joint aches and pain, significant fatigue, it's difficult for them to resume their work completely, etc. And if you examine the patient and you don't find changes objectively on their exam, one of the common things we tend to think of is that we are dealing with a psychiatric picture. And I think this becomes further compounded by the fact that some patients with particularly neuroborreliosis do actually have mild psychiatric problems or neuropsychiatric problems or neurocognitive problems from the infectious process itself. But that doesn't mean that, you could not have a separate, process involving your skeletal body, your muscles and so on. So I think the tendency is, well, you're depressed or you're anxious or, you're thinking too much about it, you have a somatization disorder, etc. In my experience, most patients do not have somatization or depression as the only problem or as the main problem. It's usually can be a co-partner, but they usually, if you really do a careful exam on them, particularly in our field in neurology, you will find that something is not right on the exam, and probably some residual sequela to your nervous system has persisted. And these patients, particularly if they were very, very high functioning people before the infection happened, they go down from 100 miles an hour to 30 miles an hour. If you're meeting them for the first time or for the second time, you may not see anything wrong with that, but to them this is wrong, because that is a decrease in their function and in their speed by a factor of 2, you see, down to 1/3. So I think if you think about it this way and you put it in perspective, you can see what the patient feels. And that, again, is another component of the education process, yeah. The presentation was, in many of these cases, was really not because they thought or they remembered being bit by a tick. The reason why we had high index of suspicion is they've had they've have symptoms of suggestive of some type of an inflammatory or a low-grade infectious process, number one. Number two, on their examination, all these patients, including that particular patient, had findings on their exam suggesting that the peripheral nerve as well as the roots were affected. And by taking a careful history, there was a brief period of time where there was also perhaps some irritation or inflammation in the meninges. They've had headaches. They had a little bit of neck pain, back pain, shoulder pain, etc. And there was a clear-cut finite period of time where they really could not function very, very well. They were pretty sick. And the interesting thing about these patients is that they were tested by rheumatologists, to see if they have a rheumatologic disease. Did they have rheumatoid? They did not. Did they have lupus? They did not. We have a couple of women in the series who did not have lupus, but they were tested for it. But there seemed to be a little bit of a pause there, and nobody seems to think, well, could it be something like Lyme? And the interesting thing is we tend to test, for instance, for HIV in these patients, even when we think they are very low risk for HIV. Or sometimes we test them for syphilis. But you're more likely to test for those or for hepatitis than you are for Lyme. So I think what happened in this particular case, the presentation could fit with Lyme. So we did the testing for Lyme. And at least the 5 patients or so we did also spinal taps. And the lumbar puncture suggested they have that. And I think that, once you find this out first, this is really, believe it or not, a good diagnosis to have, because this is something you could treat, The second thing is, then at least it puts to rest the issue about the patient being, just pure psychiatric or mental case, so to speak, forgive the expression. And the third thing is, it allows you to understand, particularly if you treat these patients with the prognosis, what else is going on with their system, what subsystem in their body got affected. Was it the brain? Was it the spinal cord? Was it the peripheral nerves? And then perhaps address the treatment accordingly. So I think, the key thing is, if the picture is suggestive and is consistent, and if you're going to be doing a detailed rheumatologic workup, perhaps before doing biopsies and some other really significantly invasive procedure, maybe just, do the testing and think about it. And in the case of neurology, if you really think there is a strong likelihood this may be a neuroborreliosis, a lumbar puncture is really worth it. It may provide lots of relief down the road for the patient. I think the frustration can be further compounded if all the caregivers you've seen, the physicians, the mid-level providers like nurse practitioner, physician assistant, don't think that this could be potentially related to your Lyme. I think that adds to your frustration. I think, in my experience, not all, but most patients, if you give them a valid explanation for why their issue is there, why the symptoms are there, and if you can work out a schedule or a program by which there is a good, if you will, management of their energy levels and of their symptoms, most patients actually do reasonably well, I think. So I think basically it's a two-way stream, and talking to the patient and figuring out that every patient is really different, whether they have the disease or not, because ultimately, your health before the condition, your genetic very likely makeup, your epigenetics, how your life is going, how many kids you have, do you have a supportive spouse or partner, all these factors, becomes part of the equation. It's a factorial equation, and every person is different, and you just have to work with that person.